Uh, I welcome all the participants and panelists to this discussion that we are having today on a very critical topic, that's role of public health law in cancer prevention. On behalf of National Law University Odisha, I, Nandita, welcome all our distinguished guests for today to virtually to this event on behalf of NLUO. Uh, the topic that we are going to discuss today is quite sensitive because cancer, according to World Health Organization, is the second most fatal disease that we have. Diseases dread everyone. So it's very important that we talk about how to prevent them, especially in a country like ours where we have very scarce resources and financial burden of a disease like cancer can run financial and emotional havoc on families and health systems. I now request our Vice Chancellor, Professor Ved, to formally welcome all our distinguished guests. Over to you, ma'am.
Good afternoon, everyone. I'm so happy that today we are focusing on the issue of cancer. And having gone through it myself, I do know that it's not easy for people to deal with this issue. And I remember that when I shared this fact that I was suffering from cancer on my Facebook, 500 people responded to it saying, oh, we wish you well, take care. But not even one of them uttered the word cancer. Because after more than 500 comments on my status, that somebody wrote, oh, you got cancer. And then I realized that cancer actually is a taboo word. I did not know this was also in the dictionary of taboo words, that you don't tell people that you have got cancer or you have got a problem with that. And then I think there's so many unknowns. I knew that I had to have a chemotherapy, but I had no idea what happens in chemotherapy. And that was giving me more jitters once I had more. Hi, Dr. Majid, I'm so happy that you are here. Waiting for you. He's my surgeon. And I really wanted to, certainly want to welcome each one of you, but especially Dr. Majid, who is responsible for the way I responded to my diagnosis of cancer. When I met him, he said, you did not know yesterday that you had cancer. You know that you're better today. So has anything actually changed in your body? And I said, no. He said, I'll take out the cancer from your body. From your mind, you will have to take it. And I think that was for me the key words which have really helped me to deal with it. I did not think it was anything else than any other illness I had. And I think in that sense, I really feel very closely when people say it's cancer survivor. I don't think I am the right one entitled to that title because I did not survive at all. I didn't have to deal with cancer at all. It was my doctor who were dealing with that. And I think that's something which we all need to learn about public health, because I think public health is a lot more to do with the mindset rather than just the disease. The fact that people get half dead just listening, hearing that, oh, such and such person got a cancer. I think that was certainly a time when it was very dreaded. But today, a lot more people survive than I think die. Certainly, at this point of time, we as a faculty are very worried about one of our colleagues who is having his 4th stage cancer. And that's a concern. All of us are very bright young colleague. And therefore, I think this is at the right time to get some more education, some more focus on this subject. I'm very happy that the Center for Public Health, in collaboration with the Public Health Foundation of India, has decided to focus on this subject. I welcome all the panelists, and I look forward to more sessions on public health through this forum. Thank you very much.
Thank you so much, ma'am. For the benefit of all the participants, I'll just introduce and give a brief intro about our panelists. We have today with us Dr. Shefalika Goenka, who is from Public Health Foundation. She is the head of bioethics at Public Health Foundation, also head of Department of Social and Behavioral Sciences at Indian Institute of Health, and head physical activity and obesity prevention, Center for Chronic Diseases. She is the commissioner for Lancet Obesity Commission. We have Dr. Sharmila Pimple. She is professor and physician, Department of Preventive Oncology at Tata Memorial Center, Mumbai. We have Dr. Shipra Gehlot. She is a consultant physician at Healthcare Clinic in Lucknow. We have Dr. Majid, whom ma'am introduced. He is a senior consultant and head surgical oncology, Batra Hospital, New Delhi. We have Dr. Nandini. She's joined. Yes, she's joined. She's a clinical consultant, palliative care at BARC Hospital. Also, is an honorary consultant at KEM Hospital, Mumbai, and also consultant with the National Cancer Grid. We have David Peterson from the Faculty of Groningen. And lastly, we have Dr. Amit Yadav, who is a senior technical advisor from International Union Against Tuberculosis and Lung Diseases. And we have our registrar, sir, Professor Yogesh Pratap, and our Vice Chancellor, Professor Ved Kumari. So according to the schedule that we have for today, we have 6 minutes for each of the speakers who will be talking on an allocated topic relating to cancer prevention. I would request all the speakers to please adhere to time limit so that we maintain the time, we complete in the time. First of all, I'll invite Dr. Shefalika Goenka to please tell us in brief about Public Health Foundation and its collaboration with National Law University. Dr. Shefalika Goenka, over to you.
Thank you very much, Nandita, for this fabulous introduction and taking this webinar forward. On behalf of the Public Health Foundation of India, it's with great pleasure that I speak today. Congratulations to the vision of the National Law University to set up this first Department of Public Health Law in the country. And congratulations to the extraordinary leadership of the Vice Chancellor, Dr. Ved Kumari, and the dynamism of the head of department, Dr. Yogesh Pratap Singh. As soon as we got into conversation, which was facilitated by Amit Yadav, everything moved forward with extraordinary speed. So congratulations to him. Public Health Foundation of India works collaboratively with a range of stakeholders, including many state governments and central government, philanthropists, civil society, and academia. The government enabled its formation in 2006. Since its inception, we also do a lot of evidence-based public health and research in various domain areas like cancer prevention, cardiovascular diseases, diabetes prevention, social behavioral sciences, maternal child health, environmental health, health economics, and affordable health technologies. We have 5 functioning institutes of public health under the Public Health Foundation of India in various parts of India: Gandhinagar, Hyderabad, Bangalore, Bhubaneswar, Delhi, and Shillong. At the Public Health Foundation of India, we believe that health is multidisciplinary, not just with doctors. It's in the hands of lawyers like you. It's in the hands of behavioral social scientists, in the hands of engineers, urban planners, geography experts, philosophers, and so on. As you are students of law, as you move ahead, you will realize that the power which you have in your hands. For example, today the drop in the cancers due to tobacco, 50% of cancers in India are due to tobacco. 50% drop in tobacco use has happened because of the laws which we created and implemented, and not because of the doctors. Similarly, for example, the built environment has a huge role to play in the prevalence of hypertension, diabetes, and cancers in a location, because it enables physical activity in an area, as well as the air pollution levels are determined by the built environment. So on and so forth. And you will hear more about cancer prevention as we move along. And this was just a little example as to the power which is there in your hands to prevent diseases at the population level in large numbers of people. Over to you. Thank you very much.
Thank you so much, ma'am, for relating the subject of law and its importance in public health. It's with that in mind that we had set up this Center for Public Health at our university. I now would request Dr. Sharmila Pimple to please set the agenda and share with us some views on burden of cancer in India and what are the key preventive measures at various stages. Dr. Sharmila, over to you.
So thank you, Nandita, but you got to share, I have to share my screen. Yeah, you'll have to allow me.
I'll just do that, ma'am. Ma'am, I'm giving you the presenter rights. You can share the screen.
Well, thank you for giving this opportunity actually, and it's a different kind of presentation that I'm going to do for the law students for the first time. And I hope, I'll satisfy the requirements of this particular webinar. So the 6 minutes is too less a time for an academic teacher like me, but then I'll try to go as fast as possible because I need to tell too many things. So, yeah, giving a perspective on the cancer prevention and just the burden for the country. I want to give this particularly to acknowledge that currently, if you look at India, and these are our cancer registry figures, okay, I just want to make the audience spot the difference between the current rates of cancer incidence for USA, Australia, versus India. So considering the comparison, we seem to be pretty less. Okay, but apart from the burden, the thing is the rising incidence of cancer, of various types for cancer for that matter, and the changing incidence. If you see in the 1990s what we were, and I mean in the current decade, and the changes that has happened, some of the states which have taken over in terms of the cancer burden. So this is very significant. And quickly, if you see, in terms of the various types of cancers, we see uterine cancer, cervical cancer burden decreasing, breast cancer burden increasing at a great speed, in fact, for that matter. Some of the cancers, which were very, very low, like corpus uteri and ovarian cancers, we are seeing an increasing trend in our country. Again, lung cancer trends, both in the males as well as for the females, colorectal cancer trends, as we can see. So, this is some of the things, some of the prominent cancers here, and we see that the incidence is rising. And then, of course, things have to be attributed towards our changing lifestyles, urbanization, and many etiological components as we proceed. So overall, rising burden of cancer for the country. Now, if you look at the current cancer burden, and which are the 5 prominent cancers, so overall we see that breast, lip oral cavity cancers, cervical cancers, that's the mouth of the uterine cervix, lung cancers and stomach cancers are the 5 main cancers for the country, which we got to be worried about. Well, in terms of the cancer, we understand that there are, we have risk factors for cancer. So many ask, what are the etiology behind the cancer? So we have some risk factors which are modifiable, wherein, we can take appropriate measures, whereas some of the factors are non-modifiable in terms of ethnicity, of course, sex, heredity, and as we age, the incidence of cancer is going to rise. Now, in terms of prevention, that's where I'm supposed to be giving an overview. We usually talk about 3-4 levels of prevention. Primordial is the one wherein we do not want the risk factors to be rising. Primary prevention, we are trying to control the risk factors and also in terms of delivery of some vaccine programs in order to prevent the occurrence of the disease. When we come to secondary prevention, we are wanting to detect these cancers, screen these cancers and detect them in a very, very early stage so that they can be treated. And of course, tertiary prevention in terms of the treatment so that we can reduce ongoing morbidity, mortality, or deaths due to cancers once they are diagnosed. So the risk factors, when we talk about primordial prevention and primary preventions. So cancer is one of the non-communicable diseases, okay, contributing towards increase incidence, mortality from this cancer, and the common behavioral risk factors which cancer shares with the other non-communicable diseases like cardiovascular diseases, respiratory disease, and so forth. tobacco use, harmful use of alcohol, lack of physical activity, and excess energy intake, mean to say unhealthy diet, are the ones which are common. And on the other side, I'm just reflecting as to how these kind of, common risk factors share their contribution in developed world versus the developing world. And we see that tobacco infections, okay, diet, nutrition, the proportion differs. And this ultimately is attributable towards the urbanization, industrialization, changing lifestyle, changing patterns. So, so on and so forth. So, primarily what we look at is, we look at primary prevention, secondary prevention in terms of doing the necessary testing, and tertiary prevention because all the testing, screening, diagnostics have to be ultimately linked towards appropriate treatment. And one of the common examples which I cite is, we can look at cervical cancer prevention, wherein in primary prevention, we can look at vaccinating human papilloma virus vaccines are the ones which are on the horizon, and more than 100 countries have already adopted it. So primary prevention could be started with HPV vaccination. Secondary prevention in terms of eligible women getting screened and with a suitable screening test. And once detected, they can be linked towards appropriate treatment. For tertiary, in terms of, as we know and as we understand, treatment combines radiotherapy, chemotherapy, palliative care, etc. So, coming to the perspective which I want to lend in terms of primary prevention for cancers and the common risk factors that are being shared. So, the key considerations for the use of law for non-communicable diseases, we do have health policies, and health policies exist, and whether we take the course of the recourse to the law or not is highly dependent upon how we want to use this law, and may want to choose to use this law as a tool for implementation. So overall, laws and regulation do provide tools for policy implementation, which can be backed by enforcement, procedures for the redressal of the damages, etc. So laws and regulations can restrict access to carcinogens or facilitate or motivate healthy behaviors that are wanted. So herein, in terms of the law in global non-communicable diseases governance, so we do look at implementation because implementation is multi-sectorial, and population-wide interventions are needed, and legislative and regulatory measures are one of the measures which can govern appropriate implementation and enforcement. So the Global Action Plan for the Prevention and Control of Non-Communicable Diseases, for which cancer shares the common risk factors. We have the WHO Framework Convention for Tobacco Control. We have the Global Strategy for the Harmful Use of Alcohol, Global Strategy for Diet, Physical Activity and Health, and all encompass and contain recommendations for the use of law in NCD prevention. So, I cannot but help give the stark examples of the big food, big tobacco, and big alcohol, wherein the laws in tobacco control, the laws in alcohol policy, the laws for the control of unhealthy diet, etc., all have been incorporated, and wherein we have used and we have taken the recourse of law for implementing certain aspects, getting into certain aspects, so that enforcement could be undertaken for all these aspects for tobacco control, alcohol policy, as well as diet policies. As I know, I'm short on time, but tobacco control law provides a perfect example of how tobacco legislation across globe in various country contexts was utilized for actually bringing down the tobacco use within these member countries. Okay, so we do not have, but these are all the measures which have been incorporated into the famous COTPA regulation for tobacco control in our country also. So overall, law is essential for to implement a number of globally agreed the best buys for the non-communicable diseases. And we look at evidence-based interventions which are considered most cost-effective and feasible for implementation in the low and low-middle income countries. So overall, when we look at prevention, recourse to law has been one of the strategies for getting control or handle onto the risk factors control for cancer prevention. And of course, secondary prevention, as we understand that not all cancers can be prevented or detected early. So for our country, we look at control for screening for cervical cancer, breast cancer and oral cancers, which have been incorporated into the prevention, screening and control of non-communicable diseases program of the government of India, which has been implemented for these three cancers. So I mean, wherein we have some screening strategies, some screening tools, which can be implemented in a programmatic setting. And last but not the least, screening is not the only thing. Screening has to be linked towards appropriate treatment. And screening for cancers encompasses a lot of other things in terms of affordability, adequate coverage, accessibility, which can be accorded to the population who is seeking services, a very functional referral system, scaling up of the overall capacity of the health system in order to treat these patients as we are witnessing in the current COVID situation within the country. So with all this, I would conclude that legislative and regulatory actions lie at the heart of the success and local strategies for the non-communicable diseases prevention control. Governments have to use health policy, but I mean, which they use in terms of education, but regulation and other aspects are kind of have to be incorporated, and they can help for more, for the appropriate decision making as well as the implementation and enforcement of these particular strategies for tobacco control, for various risk factor control. So to set the example, rapid progress in tobacco control has never been accidental, and regulation, tobacco legislation have played the biggest role and reflects the critical importance of law to the prevention of risk factors for the country. And I end my talk here. Thank you so much.
Thank you so much, ma'am, for setting this in motion with concrete examples from tobacco and alcohol control and how much we have attained. Whatever we can do as lawyers, in framing better laws, I guess that will be the next agenda forward. Thank you so much, ma'am, for highlighting that. I would now invite Dr. Shipra Gehlot from Healthcare Clinic Lucknow, who will be talking us on challenges in diagnostic access to appropriate treatment. Over to you, ma'am.
Hello, everyone. Good evening, everyone. So my topic is challenges in diagnosis, access to appropriate treatment. So as we all know that the burden of cancer is rapidly increasing in India. The projected incidence of patients with cancer in India among male was 94.1 per 1 lakh and among female was 103 per 1 lakh for the year 2020 as per National Cancer Registry program. So almost 75 to 80% of patients have advanced disease, stage 3 to 4 at the time of diagnosis. This is due to late presentation, which in turn is due to low level of awareness in population and among community physicians. What happens when a patient comes to a general physician? He interprets the presented symptoms, but linking interpreted symptoms to cancer is very complex because so many patients have only very vague symptoms. I give you an example. When a patient comes to a GP, general physician, with the chief complaints of altered bowel habits, so the physician and the patient is very young, I say 40 years of age patient comes with the chief complaints of altered bowel habit. The physician thinks that he may be a case of IBS and he starts treating him as a case of IBS for a long time. And after some time, the same patient, when he comes with the chief complaints of bleeding PR, only then the physician thinks, oh, this may be a case of CA colon. And then he refers that patient to higher centers. Till then it becomes very late. So misdiagnosis is a big challenge for a cancer specialist. And next thing is that in India, I'm giving you another example. In India, where tuberculosis is very common, and symptoms of tuberculosis and lung cancer overlap, as do so several of their findings on chest X-ray and CT scan. So patients with limited access to experienced doctors may get first treated with ATT and before diagnosis of lung cancer is ultimately made. So specialized cancer care is very important, but because of absence of oncologists and oncopathologists at primary and secondary healthcare centers, chances of misdiagnosis are very common, and that is again a challenge is making a diagnosis. So this delay in making a diagnosis may hinder the core objective of a screening program, that is improve survival and prognosis. So shortening of the longest diagnostic interval may be linked to a higher 5-year survival. So this was the first challenge, that lack of awareness. The second challenge is lack of screening programs. We all know that screening means to detect disease early in asymptomatic individuals with the goal of decreasing morbidity and mortality, and has been shown to do so in cervical, colon, and breast cancer. One of the major reasons for not being able to implement in screening programs in India has been lack of workforce, physicians, oncologists, oncopathologists, technical staff, health workers. While many tertiary care centers have a comprehensive team of professionals comprising of medical, radiation, surgical, oncologist, pain and palliative care experts. So a complex team like this is yet to be a reality in rural India. So this is the second challenge. Now coming to the third challenge, that is the lack of diagnostic facilities locally and vast distance to travel to reach a major tertiary care. So we all know that diagnosis of cancer relies most heavily on invasive tissue biopsy, and no non-invasive tissue diagnostic test is sufficient to define a disease process as cancer. Although in rare cases like thyroid nodule, FNAC is acceptable. So due to absence of oncopathologists at primary and secondary healthcare centers, evaluation of the histology of the tumor, its staging, grading, invasiveness, and to yield further molecular diagnostic information that typify a particular cancer becomes a challenge in diagnosing the extent of the disease. So because only some blood tests, chest x-ray, ultrasound are available at primary and secondary healthcare centers, and other tests like CT, MRI, PET scan, endoscopy are not available at PSC or CSC. So occasionally, and third thing, occasionally a patient presents with a metastatic disease process that is defined as cancer on biopsy, but no apparent primary site of disease. That is again a challenge. Efforts should be made to define the primary site of disease based on age, sex, site of involvement, histology, tumor marker, and personal and family history. So these are the three challenges. Now coming to the fourth challenge, and this is the most important challenge in India, in developing country like India, that is financial constraints and stigma associated with the diagnosis. So most Indians don't have health policies. So they spend their whole money on treatment and most of them tend to discontinue treatment because lack of money. And all of us know that treatment of cancer is very expensive. So these patients, they go to some quack and they think that now this is their destiny, now nothing can happen. So at this stage, the role of health policies and the role of public health law becomes very important. Now coming to the stigma part. So the stigma part, we take an example of two patients. One patient suffering from aortic stenosis and who presents with CHF. So that patient, his median survival survival maybe 8 months, and that patient may remain functional and maintain self-image as a fully intact person. But the second person who is suffering from pancreatic cancer, CA pancreas, by contrast, that patient has completely altered self-image and viewed differently by family and anyone who knows the disease. This is the social stigma that comes as a challenge. Now, coming to the last challenge, and I can't finish my talk without this. This is the challenge in today's scenario in COVID times. So when there is nationwide lockdown due to COVID everywhere, so now the patients are finding it very difficult to go to the hospital. Hospitals are closed and they are not attending new patients, and they have stopped their OPD services. So where the new patients will go? So this is a challenge to diagnose these new patients and treat these new patients. If you allow me, I just want to tell something about the treatment part also. वैसे Shefali ma'am has told everything, but I would like to tell that the goal of cancer treatment is first to eradicate the cancer, and if this is not possible, the goal shift to palliation, the amelioration of the symptom, and the preservation of quality of life. So from information on the extent of the disease and the prognosis in conjunction with the patient wishes, it is determined whether the treatment approach should be curative or palliative. So we all know that the application of current treatment techniques like surgery, radiation, chemotherapy, biologic therapies, these all results in a cure of nearly 2 of 3 patients diagnosed with cancer. But because here we are talking about prevention of cancer, so primary prevention, as ma'am has already told, that primary prevention is the most cost-effective program as it aims to reduce the incidence of cancer by risk factor modification. It has been estimated that 9 modifiable risk factors are responsible for more than 1/3 of the cancers worldwide. Now, what are they? Ma'am has already told: smoking, alcohol consumption, obesity, physical inactivity, low fruit and vegetable consumption, unsafe sex, air pollution, indoor smoke from household fuels, and contaminated injections. So next, 50% of all cancers in males are tobacco related and can be prevented by anti-tobacco program. So the patient who stops smoking has 30 to 50% less 10-year mortality due to lung carcinoma. Teenage students need to be targeted. School curriculum should involve measures for healthy lifestyle and warn about harmful effects of tobacco and alcohol. Law should be enforced for prohibiting tobacco advertisement and sale of tobacco to youngsters. Healthy diet rich in fruit and vegetables should be promoted at local level. Uterine and cervical cancer can be controlled by practicing genital hygiene and safe sexual practices. Cervical cytology, pap smear screening program should be promoted, and self breast examination program should be promoted. Hepatitis B vaccine, HPV vaccine should be promoted. So after this, palliative treatment and psychiatric treatment of not only of the patient but of the family is also important. So that can be provided to a cancer patient. And as a physician, these are the challenges that we face on our day-to-day basis. Thank you very much.
Thank you so much, ma'am. You've covered. I know we have a short time span for all the speakers.
I had to finish it within 6 minutes.
We should have increased. We should have increased, and maybe divided it into sessions.
Yeah,
that was a better way.
I was very fast. Yeah.
We'll plan it better so that all the speakers can get proper time in the next session. It's just that because we have a lot of doctors on with us, we thought to restrict the time because they might be attending to the duty. So that's the reason we fixed it the other way. But thank you so much, ma'am, for comprehensively covering the practical aspects of the cancer excess treatment that we have in India. Indeed, you've highlighted very pertinent points relating to COVID or non-availability of the physicians who are there. Thank you so much, ma'am. Next, we have Dr. Majid, who is going to tell us about the various problems which are there in cancer surgery. And as Professor Ved highlighted, the problem that she herself faced, it's more of a mind issue, and how Dr. Majid tackled that. Dr. Majid, over to you. We would want to hear more such stories of patients and how you handle this body-mind balance. So over to you.
Yeah, good evening. And I would like to share some slides to be the cancer basis. But my dear patients, for example, Ved Kumari, you can see how beautiful face she has. Share my slides, please. I just want to share my slides.
So you will be able to do that now.
Yeah. Thank you very much for the permission. Did you hear what did I say before? Okay. Basically,
yes, sir.
Yeah. To be very honest, if you see this, what we are discussing today is nearly around 10 lakh people are diagnosed, and so sad that at the end of the year, nearly 10 lakh patients do not survive. So there are many problems which we face, and the results what we are getting today, it's like nearly, if you see, 80% of the patients present in a last stage, a terminal stage, from where they cannot be, treated. So these are the major challenges what we have in front of us. The first and foremost challenge which every patient faces is the moment if someone tells me that you're diagnosed with cancer, the first thing can come to my mind is, how can I develop cancer? It will be a shock, a dilemma for me. And believe me, even very big intellectuals, players, for example, Yuvraj told me that he took 3 months to come out from this dilemma, that a fit cricket player like me, how could I develop this? And today you see he's all good. He traveled to different countries, from India to US, England, and then suddenly he said, yes, This is a disease which you and me can develop. It is a natural process in some bodies. So we all face this problem of shock and dilemma that how can I develop cancer? And this can very well, a person can come out of this. Like how, or else what happens is, the disease is very misleading because in initial stage, like stage 1, where the chances of cure are nearly 100%, stage 2, when the chances of cure are nearly 80%, the person has no symptoms. For example, if you see Manisha Koirala, she was standing on a stage and she suddenly collapsed. Then she was rushed to a hospital. Then there the doctor said, you have a tumor, it's an ovarian tumor, which you have in your abdomen. And the size of the tumor is nearly more than 20 centimeters. And for her, it was a shock. How can I have such a huge tumor inside my abdomen? See, in an abdomen, you can easily place a football inside and you will not come to know. And she was 42 years. She thought maybe that I am growing old. Maybe because of that, my abdomen is coming up. So these are the misleading symptoms. Normally, a cancer patient has many symptoms. Like for an oral cancer patient has a pain in the mouth, an ulcer in the mouth, not able to breathe properly, having difficulty in swallowing, loss of weight, loss of appetite, pain in abdomen, jaundice, so many symptoms the patient has. But by the time the symptom comes, it's nearly late. Most of the symptoms which are challenge for us is to diagnose the patient in an early stage, and that's possible only through screening. And normally, once I'm diagnosed with cancer, I always feel I shouldn't undergo a surgery or a chemotherapy or a radiation. I should develop some shortcuts. And immediately someone comes and says, you go here, there's a cure for this. You go to or there are some religious cures, or there are some quacks who are advertising. Like in Corona, they say, in 2 days we cure Corona. We have a complete cure for cancer. These misleading advertisements by quacks, unqualified people, are a big, big danger to our society. And these people misguide the early symptoms, early stage cancer patients, leading them to go for the last stage. And they come to us in a last stage where the chances of cure come down. So these are the few challenges. And if you see the treatment, naturally, whenever I offer someone a treatment like surgery, for example, I need to remove your uterus, the patient says, oh, if you remove my uterus, what about how will I get pregnant? What will be my sexual life? What will be my social life? So many things come to our mind. See, what usually happens is when you remove the uterus, it's only you cannot produce children, but you can have your normal husband and wife relationship, and you can have the normal life. And for example, some people who have colon cancer, I tell them you'll have a bag, a colostomy. Believe me, I have a football player who is playing football with a bag and he's doing well. He got married to a celebrity also. So these are the things, myths related to surgery, like you get handicapped. See, surgery sometimes, there is so many problems, but those are time being. But your long, healthy future life, you will lead normal life like the others. So we cannot, say about that. For example, chemotherapy, people say, see, the hairs go and all that. You see, I always tell my patients, see, the hairs will go, but 100% you'll have the hairs, and sometimes you may get your white hairs can turn into black hairs. So like this way, we have to, the challenges which are there. See, the chemotherapy, no doubt, kills the cancer cells. And sometimes few normal cells will be damaged, but this is a temporary phenomenon. The cancer cells die forever, and the normal cells which are dead regenerate. Radiation, people say, oh, if you give radiation, maybe your face becomes black. Yes, but after a month, it comes back to a normal fair color. They say, you're not able to eat, you're not able to, no, these are all temporary. Now the surgery has changed. For example, in breast cancer, you remove the lump, you preserve the breast. You remove the breast, you make a new breast. Like this way, there are modifications. The treatment has become targeted. For example, in radiation, for example, if there is a tumor is like, for example, like my pen or a tip of my pen. We nowadays, like in earlier days, we used to target the whole pen or the whole lung. No, now the treatment has changed. We target the pinpoint tumor in whatever shape it is. So the side effects are less. So like this, people are having a phobia for treatment. No, the treatment has changed and the treatment is miraculous. Today, We have 100% cure in cancer. And these are the myths, these are the challenges we need to overcome. If you see why the problem is the cancer spreads. If you get diverted the moment someone tells you have cancer, then what happens? Your disease spreads locally, your disease spreads through blood, your disease spreads through lymphatics. And the disease which was in stage 1, which is curable, you land up with a disease which is 100% non-curable because you've wasted the crucial time. You need to be bold. You need to take a decision. So once I declare someone you have a cancer, the challenges which the patient faces are the patient feels physically weak because the patient stops eating. Emotionally, patient gets anxious. The patient may go into depression, irritability, poor concentration, inability to do its normal routine duty. There's a lack of sleep because a person feels that probably there's uncertainty. No. There is a fear of death. No. There is a the fear of disfigurement. There's a fear of disability, infertility, dependency, abandonment, financial hardships. I will give only one example. Honorable Madam is here. She has overcome all this. And you see how well a person comes back much better than before. And you go to newer heights. So these are the challenges which every patient needs to overcome. There are simple myths, like in a biopsy, a person takes. There are myths. People say you take a biopsy, the disease spreads. No, the disease does not spread by taking biopsy, but we come to a conclusion that you do not have cancer or you have cancer and you get treated. There are so many fake advertisements all over, saying that this will treat cancer, that will, like for corona, you see, there's so many myths coming up. The fear of side effects take you away from the treatment. Some very highly qualified people, they go for partial treatment. You take surgery, radiation. No, you need to take complete treatment. And for that, we need to take the concept that complete treatment is mandatory now. And in future, the disease doesn't come back. That's why we are giving you a complete treatment. There's a fear. Believe me, if it can come to you, come to me, it can come to anyone. So why are we having the fear that the disease will come back? It can come to anyone. So what are the three solutions for it? The treating team, if I'm treating my 3 months, you'll have to slow down. You need to take complete treatment. These are the side effects, but these are temporary. But you'll have future. You need to give to the patient. And what plays a major role is the activities, spending time with family and friends. We need to take counseling from the experts, families, and friends. We need to get involved, like meditate, go into religious activities, and financial support from friends, family, resources. We need to see. I always believe, whenever I speak, I always say health is a fundamental right. A person should get bed, person should get medicine. There should be no black marketing of medicine. This is what I thoroughly believe and always recommend it whenever I'm in any of the platforms. See, we should all have universal health insurance policy. What does that universal health policy insurance mean? That every individual should get quality care at an affordable price at the doorsteps. You see, it needs modification. Giving a tax no one is able to take. If the Ayushman Bharat was strong in Corona, we would have not faced it. Similarly, for example, you cannot pay 10 rupees for a procedure will catch 200 rupees. So we need to have a proper guidance in the Ayushman Bharat. Capping of life-saving medicines. You cannot sell 100 rupees oxygen cylinder for 50,000 rupees. You cannot send chemotherapy medications at a very higher rate. The government needs to cap all of them. We need to do it before it costs. In mind how many cancer patients we have and how many we are going to have 10 years later. So we need to have equal distribution of resources. We need to have equal number of doctors, infrastructure, and all that. Yes, Do you think taxation is good in health? I think no, because the patient has to pay from its pocket from a deathbed. So we need to think where to tax, where not to tax. People should be given special loans. Why? When I have a cancer, I don't have a family support, I can go to the bank and take a loan for the cancer patient, special loans. The private hospital policy.
I believe Dr. Majid is
I've already
experiencing.
discussed.
So there was a break.
I think
Lost. We couldn't hear you for.
I'm there again.
Minutes. Yes,
Okay,
yes,
no
there.
problem.
Very much.
We need to have more doctors. We need to produce them. We need to have more infrastructure, nursing staff, paramedical staff, everything, building medical staff. For 40, whoever we are healthy, we need to undergo screening. I don't say cancer screening. I mean to say health checkup. Many things will be diagnosed after that. And after 40, we all tend to start more research needs to be done, whether it's in the field of surgery, chemotherapy, radiation, not like corona or like tuberculosis, and hence require education, educating the society, and we need. Are you able to hear me? Yeah.
Yes.
Can you?
Yes, sir. Your voice is breaking in between, but now it's proper. Can you hear us, sir?
Yeah.
There is some technical. Yes, sir. So, do you have something else to continue? Some more slides?
No, I think I'm done. Okay. Thank you very much.
Thank you, sir. Thank you so much, sir. That was really enthusiastic, listening to a doctor covering so many aspects. I'm sure your patients, with your energy, they have, the fear itself has dispelled, not because of what you talk, but the way you talk. So then thanks, sir, for, clarifying all these myths and fears that we have and how family, society itself can come to support. We need proper systems in place. And we really appreciate the fact that you've mentioned about law, how it can shape. But as a teacher of public health law, let me tell you, one of the problems that I face with law is all of this is done through executive policy. Nothing is done through law, and courts rarely interfere with executive policy. So we need to take that into account. So the recent fiasco with the vaccine policy that we have, similarly with Ayushman Bharat, it has not come through a law, it has come through a policy. So you don't get rights under a policy. That's one problem that we face. Yes, we need to address them as well. But thank you so much, sir, for such an enthusiastic way of communicating various nuances of cancer, surgery and treatment in India. Thank you so much, sir. Next, we have Dr. Nandini V, who will be talking to us on palliative care, various aspects of palliative care, especially its role in cancer treatment, and what are the challenges and the barriers that she has faced. Ma'am has joined us from Mumbai. Dr. Nandini V, over to you, ma'am.
Thank you. And I hope I'm audible.
Yes, ma'am, you are.
Okay. So a big congratulations for this organizing team for bringing this discussion of the king of maladies, regarding the king of maladies with the law students, because, cancer is like the Ravana, which makes all the other villains of different epics like Dushasana, Duryodhana, or Shakuni into pale into insignificance. It has all features, all the diseases together. So cancer is very considered as a chronic, severe life, the daily functions, as well as the, burdensome symptoms, treatment, caregiver stress, and it has it all. And why is it a public health concern? Of course, if it was easily, you have heard from all the speakers before as to why it is a public health concern, because until even the statistics which have been quoted are regarding, whatever has reached a hospital environment. If they don't reach, they're all walking around. People around you may be already having cancer, but it has not been detected. So 80% of cancer, they seek oncology service already in advanced stage. So when it is in that way in the community, what happens is the preventive policies, there is a lacunae because of that. And secondly, there is a big imperative to provide and respond to the needs of these people who are diagnosed only in the advanced stage. We cannot say, okay, it's not curable, and then nothing more can be done. These people are not going to die the next day or the next week or even the next year. They may live long, and we need to make sure that they live in dignity and they live with comfort and free of symptoms. So there is, everybody knows about cancer-related suffering. It cannot be overemphasized. The first thing that a person thinks of when they get cancer is about the pain. Will I suffer? So it cannot be relieved without professional intervention. And the suffering is, it cannot be relieved without professional intervention. And it compromises the physical, social, spiritual, and emotional functioning, which several speakers have emphasized upon. So this suffering is also a public health concern. So this is named currently as serious health-related suffering, and cancer is one of the biggest reasons for serious health-related suffering in the community. And of course, it is not just physical, it is also emotional, social, spiritual. And of course, all these put together, it makes the person completely bogged in. Now, palliative care, many of you may consider palliative care something that is available for people in the advanced stages, but it is actually defined as the active, holistic care of individuals with serious health-related suffering due to severe illness. So we need to remember that palliative care may be relevant right at diagnosis. The person who spoke earlier, he mentioned about, right at the diagnosis, how a person can go through a spectrum of emotional disturbances. So they require that extra help because it's a multidisciplinary care. Palliative care believes in multidisciplinary care and believes in active holistic care. So at diagnosis, to help them get comfortable with the diagnosis, then during treatment to allow them to complete the treatment, because sometimes the pain can come in the way. They will say, no, I cannot handle this pain of this mouth becoming so sore, I will not continue. And actually they'll miss out on a chance. And if you handle the pain, it can be, the whole treatment can be completed. Then of course, during progression and advanced stage, when there are no curative care to be offered, we always have the opportunity to make the person comfortable, handle their pain, handle their breathlessness, handle their nausea, vomiting, or manage their wounds, because patients get isolated because of a foul smelling wound, which is not necessary. Any doctor who has completed an, but just because of the name diagnosis of cancer, they stay away, and unfortunately they languish in the community at their home, and they have a miserable, undignified death. Or if they happen to have an insurance or they have money, they have a they languish and have a miserable death inside an ICU with futile interventions like ventilation and intubation, everything going on. So either way, it's a huge suffering, and financial issues, cost of futile treatment. See, we don't mind that there are all these policies come up to support a patient in treatment, but very often most of the treatment is done when the stage is almost like, for example, once a patient gets into a ventilator, then very often the doctors know within the first few days that this person may not come out. But unfortunately, the legal system around it is not clear. So let me now that I have explained some of the aspects of palliative care, let me just talk about role of public health law in preventing the cancer burden. Because now when I'm talking about palliative care, we are talking about the tertiary prevention of cancer burden, the morbidity and the mortality that Dr. Sharmila Pimple referred to earlier. So WHO explicitly recognizes palliative care under the human rights to health. And our own constitution, Indian constitution, I think it is Article 21, you may know better. It mentions the dignity to life. It includes the dignity to how our end of life would be. So all these, horrible ways of dying, either in the ICU or, leave against medical advice. Patient is asked to just leave because the doctors cannot send them home, like how our grandmothers and grandfathers used to die peacefully at home. Now it will be called, unfortunately, due to the new judgment that has come in 2018, it will be now called as passive euthanasia, which is a complete misnomer. So there are many, many corrective aspects to the law that has to come in. WHO's also brought out in its General Assembly of 2014 that it is an obligation on individual governments to strengthen palliative care as a component of public healthcare system. It also to develop and strengthen the policies to support the public health system. So now in India, we do have a national program of palliative care, which has some amount of budget, which is very difficult to access. It requires a lot of education to allow the state NHM departments to apply for it. We do have policies, like we talked about that, availability of prevention to be there in the community itself. So the health and wellness centers, which are the smallest units of the public healthcare system, are now being empowered with both preventive as well as palliative care competencies, which is a big step. So I saw the operational guidelines for palliative care in health and wellness centers being published on 14th of April, just last month. About cancer pain. It was tremendous that, in 1985, when the NDPS Act, which all of you know is the Narcotics, Drugs and Psychotropic Substance Act, which was, published in 1985, the amount of morphine consumption for pain relief was 716 kilos. And as soon as this NDPS law got published, over the first decade, it became from 716 kilos to 18 kilos. I'm talking about these numbers across India. You can imagine the impact a law can make on the absolute, symptom management of a cancer patient. So if it is so difficult, the laws was so strict, ultimately in 2014, we, after doing executive, like someone mentioned about how it is executed by the state. So we tried to change the policies in the state and offering them, modified law rules, which is different from the act, which didn't work well. And then we had a public interest litigation. And finally, through a parliamentary motion, it was passed in 2014. And now there is an amendment to the act, which makes the availability of morphine slightly easier, but still, as you said earlier, the implementation is pending. The act is there, the amendment is there, but still there is a lot of education required throughout the country to make it actually happen. Another aspect where the interface of palliative care and the law comes in is the judgment that was passed, which I mentioned a little earlier, the 9th March 2018, the law which brought out this case of Aruna Shanbag, and the passive euthanasia term was introduced, very, very unfortunately. Why it is unfortunate? Because euthanasia is the intentional act of killing a terminally ill and dying patient with an intervention, with an active intervention of a doctor. But when a person, all systems have gone, and then you prevent the prolongation of death, that is unfortunately is not euthanasia. And I think that was a big misnomer, which caused a lot of confusion and problems. And I think that is a big law issue that comes to my mind. And allowing natural death and withdrawing life-sustaining treatment to limit the suffering of a patient who is dying because of a disease should not be construed as euthanasia. Now, so ICMR has come out with a very important document defining all these in detail, and the ethical issues of terminally ill have been brought out more clearly. India has a huge opportunity now to remove the major chunk of health-related suffering by providing ethical and legal guidelines covering patients, especially with long-term, severe and incurable illness, and for those who are in the end-of-life care. Today, if I, as a healthy person, if I now want to write my advanced care directive, because, in case I fall ill and suppose I'm in a ICU with a ventilator, my advanced care directive, even if it exists, because it has to be signed off by a first-class magistrate, my relative has to inform the doctor. It is not doctors, suppose the doctor forgets to ask for it, or my relative does not say, I will go through all those, ICU and everything. But after I show the document, the doctor will check with the first-class magistrate first, whether it is authentic. Okay, here I'm dying, I'm suffering. Then the doctor has to inform the hospital policy, and they have to construe a board consisting of at least, they have listed a number of 4 or 5 specialists. They all have to visit me together. You can imagine how difficult it is. It's not like one by one. They have to, then they say, okay, this is valid request. Then they have to go to the district collector. district collector has to create another committee, and they have to again visit and discuss the case together. And so you see, it is almost impossible for me. And they have given a period of 3 months. For 3 months, I am suffering, and it is such a impractical law, to implement. It's a very good law in terms of intention. It is wonderful that at least they looked into the Advanced Care Directive. So these are the few points that I wanted to highlight in terms of this tertiary prevention of cancer burden and suffering and maintaining the dignity of life, including the dignity of dying. Thank you.
Thank you so much, ma'am, for highlighting various critical issues that I guess can form a basis for a separate discussion on palliative care that we have. The common cause judgment that you highlighted by the Constitution Bench of Supreme Court in 2018 following Aruna Shanbag. I guess we have different terminologies. Maybe law is obsessed with definitions. That's one problem. But the problem that you highlighted with respect to boards, law is fascinated with due diligence. As judges, we don't want to have blood on our hands. Probably, I'm reminded of one of the characters in Great Expectations by Charles Dickens. There was a lawyer, who kept washing his hands after every advice that he gave. So probably that's the reason. But this is not just a problem with advanced directives. With another law that we have, medical termination of pregnancy, the boards that are constituted there, and at times the women and the child, they are at crucial stage, and it leads to all kind of chaos and confusion. But there are issues that we as lawyers must discuss more in detail. Thank you so much, ma'am, for highlighting that and highlighting the human rights aspect of palliative care under Article 21. Thank you so much, ma'am, for
Thank you.
all
It was a
those
pleasure.
insights. Thank you, ma'am. I now would request David Patterson, who has joined us from University of Groningen, to please talk about the role of international law in cancer prevention. Over to you, sir. I'll share your slides. I'll do that for you.
Yeah, thank you very much. And thanks to the other speakers for really a fascinating discussion so far. And greetings from the University of Groningen. When you see my slides, just waiting for them to come up, you'll see that Groningen is a little town in the north of the Netherlands, and the Netherlands is in the north of Europe. So we're a very long way away from where you are. At the same time, there we go. Great, you can see it. And you can see the map. You can see the university was established in 1614. So it's a very prestigious university. I can't say much more about it because I was born in Sydney, Australia. So a long way from Groningen as well. Okay, let's move on to the next slide, please. Okay, quick overview. So applicable international law, and then something about the implications of that law for national and legal policy and frameworks, and then what can be done to scale up legal and policy action at national level. So the assumptions I have around the risk factors for cancer, you are the experts, medical doctors, of course, are the 4 major risk factors identified by WHO for non-communicable diseases, tobacco use, physical inactivity, the harmful use of alcohol, and unhealthy diets. But also, I would also mention the additional risk factors that we don't hear so much about, which are nuclear radiation, chemical exposure, and high UV exposure for some populations. Next slide, please. Okay, so the scope of applicable international law. Let's talk a little bit about the WHO Constitution. Now, under Article 19 of the Constitution, the WHO can make, World Health Assembly can make conventions, treaties, and of course the only one we have unfortunately up to date is the Framework Convention on Tobacco Control, which has been mentioned. This is a treaty, as you know, you would opt into it, so countries would sign on. On the other hand, the WHO can make binding regulations under Article 21, and these are opt-out. So every WHO member state is already bound by these health regulations unless they opt out. And these are the regulations that specify most famously the public health emergencies of international concern. And of course, the most famous one at the moment is COVID-19. But they can also include other public health emergencies of international concern, including nuclear radiation escape and chemical spills that cross national borders. So not limited to pandemics. Next, of course, we have go back, please. Next, we have WHO recommendations. These are made under Article 23. They're non-binding. We've already heard made mention of the many very valuable recommendations that WHO makes to member states, particularly, for example, around the best buys on non-communicable diseases, including cancer. And I think what's striking about those best buys, that every best buy that's listed has a legal component. And these have also been endorsed by the World Health Assembly. Next slide, please. We can also look at international law, human rights treaty law. This is both human rights law, both treaty and customary law. But from the treaties, we can talk about the International Covenant on Economic, Social, and Cultural Rights. Article 12 deals directly with the right to the highest attainable standard of physical and mental health. And that's where we draw most of our direction under international human rights law on the right to health. But don't forget, there are other treaties, human rights treaties relating to the rights of women, children, people with disability, migrants. All of these treaties also refer to the right to health. So there's quite a strong international legal framework under which member states will actually implement their national obligations. And these obligations can be of immediate application, or they could be progressively realized. And even in resource poor countries where these obligations it's accepted that they can be realized over time, governments still have to take immediate action. And they, for example, are expected to have national plans about how they're going to address the right to health progressively over time. And in those national plans, they may also call for international cooperation and assistance. And all states have a responsibility to offer cooperation and assistance if they can. The right to health has been explored in much more detail by the Committee on Economic, Social and Cultural Rights. They've a general comment in the year 2000, and more recently, the Committee on the Rights of the Child has issued a general comment on the right to health in 2013. Moving from human rights law to international environmental law, because it's relevant to cancer, we had the Vienna Convention on the Protection of the Ozone Layer, which addressed the penetration of harmful rays due to the depletion of the ozone, and this had a direct impact on skin cancer. Also, you can look at the Framework Convention on Climate Change. There will be impacts on skin cancer, impacts on food systems, and that food systems will have impacts on healthy diets or unhealthy diets, which will again increase cancer risk. Next slide, please. So at the national level, so of course, as law students, you know about the Constitution, the federal state division of powers, but under international human rights law, all governments, federal, have the responsibility to respect, protect, and fulfill the human rights that are set out in the international treaties. But I'd also draw your attention to the importance of civil and political rights in the right to health, because it's civil and political rights which enable civil society engagement with government around law and policy reform to respect the right to health. We've also already touched on some of the interventions for the main risk factors. A colleague may perhaps talk about the Empower framework under the Framework Convention. What about taxes on alcohol and taxes on sugar-sweetened beverages? These have been introduced in many countries to address the ill effects flowing. Marketing restrictions, particularly around advertising of junk food and drinks to children. And physical activity, there's a lot of work that can be done. Taxes on polluting vehicles and shifting to active transport, footpaths, bike paths, recreation areas, improved public safety. All of these are areas of legal frameworks which can enhance active transport and improve health. Next slide, please. So scaling up legal and policy action at the national level, there can be strategic litigation or public interest litigation that's been referred to in domestic courts. Also, under some UN human rights mechanisms, the International Covenant on Civil and Political Rights has an optional protocol which allows individual complaints. India has not signed that optional protocol yet, but hopefully will do so. Also, industry can be taken to court domestically, but not internationally, of course. There are many other mechanisms at national level which you may be familiar with. And then I'd just like to finish on a note here about the importance of interdisciplinary collaboration. I'm just so happy to participate in this webinar today because it highlights the importance of dialogue and collaboration between schools of law, schools of public health, between the medical and public health profession and the legal profession. Next slide, please. If you do have any questions, please reach out to me, and I hope to welcome you as postgraduate students to Groningen one day in the future. Thank you.
Thank you so much, sir, for that exhaustive presentation covering different aspects of international human rights law, environmental law, other aspects of national context, and telling us what India has signed and not. Thank you so much, sir. I'm sure my students will be definitely writing mails to you. We have your contacts. Thank you so much, sir. Lastly, I know we are behind schedule, but we'll quickly have, this is the last discussion that we are having. We have with us Dr. Amit Yadav. He's a senior consultant with the union, and he has been regularly advising our center at National Law University with various activities. I welcome Dr. Amit. He'll be speaking on various policy aspects relating to cancer prevention. Over to you, sir.
Thank you, Nandita. Am I audible?
Yes, sir, you are.
Thank you. Since my network is not that good and I'm remote part of my country, so I'll not be using my videos. Sorry for that. And I think it's been really interesting to hear the discussions in last 1 hour, and we have covered various aspects of cancer prevention, control, treatment, management, and even I think Professor Patterson, in terms of highlighted even the policy areas what we need to look at when we are talking about cancer prevention. I think since he has dealt with the international legal regime and how we are looking at public health law at international level, I'll try to in terms of look at some of the policy issues that we have in India. And I think in my talk I've tried to, or in terms of what I have indicated to speak on, is how different policies can help us contain the risk factors like tobacco use, alcohol abuse, and diets, and in terms of food laced with salt and sugar, and also environmental conditions. And I think as lawyers who are listening to this, and in terms of would-be lawyers listening to our talk, and other health professionals, I think preventive aspects has a very huge role to play. And it also, because it makes you aware, it makes you, forewarn you, and it makes even the later management and treatment part easier, because you are aware of certain things, and you are able to deal with those things. And I think I realize even when in terms of Dr. Nandini, I think, was talking about palliative care, and I think treatments, and even Dr. Majid was talking about how patients need to get what they want. And I know in COVID time, I think we are actually seeing how our health system it's trying to cope up with such load, and I think it has been really challenging for us. And in that scenario, I find that preventive law like the Cigarettes and Other Tobacco Products Act, which prevents tobacco consumption. So let us say having no smoking areas, having no smoking in public places, or having pictorial warning on tobacco products. I think similar things should happen for alcohol. We don't have pictorial warning for alcohol. Why? Whereas both of them, alcohol and tobacco, they are both group 1 carcinogen, and we are treating these two goods differently. Similarly, when we are looking at even environmental pollution, we are not in terms of even our pollution control boards and the national policies related to those are, I think, not in terms of properly implemented. And I think that's where also we need to upgrade ourselves, and we need to look for carbon, reducing our carbon footprint. And that's where I think the whole climate change talk becomes very relevant in terms of regulating environment. So that's another policy area where we need to look at. I think the third important aspect is also food. Food Safety and Standard Authority, the primary objective of that law itself is to provide wholesome and healthy food for people. Now, one very simple example is when, as per the food safety law, if you mix nicotine and tobacco in a food product, it is against the food safety standards. Whereas you will find that every city of this country, every place in this country, people mix tobacco in pan and they continue to chew. And India is the oral cancer capital of the world. And Northeast is the cancer, in terms of that region itself is a hugely cancer burden due to the oral cancer is very high. Odisha, because of smokeless tobacco use, which is higher in Odisha, especially the in terms of locally made smokeless tobacco products, again the oral cancer burden in Odisha would also be high. So I think that is where implementing food safety norms for those kind of products, even areca nut is a class 1 carcinogen. How are we regulating areca nut? So I think those becomes very relevant. I think in terms of policy, we need to learn some of the lessons from tobacco control, and I think use them in alcohol control and even the food. Let's say sugar. So we should have nutrition value for sugar and other food products. Let's say the fast food products. How much it is giving you calories and how much it is giving you cholesterols and fat. So I think those are important aspects when we are talking about rules or policy. So I think food policy in that sense is one of the important aspects which I think we need to look at. I think so. These are again one of the areas I will leave my thought with that. Another important area is urban planning. Environment, that can be part of the environment and green environment. But I think the physical activity, another lack of physical activity is another important cause of cancers and other CVD problems and NCD problems. I think urban planning is very important. And as we are looking at smart cities, we should look at in terms of do a health impact assessment of those smart cities and environment impact assessment of those projects, and actually build such cities where people could easily walk larger footways, footpaths, and in terms of vehicular pollutions, and I think limiting the vehicular access to people, increasing the parking fees and all those. I think those are policy areas which can be dealt, and all of these are preventive. These are not going to help in treatment, but they are going to reduce your burden of cancer overall. I think so. These are some of my thoughts, and I'm happy to listen to questions and other in terms of thoughts that people have. Thank you so much.
Thank you so much, Dr. Amit, for highlighting these 4 crucial policy areas that I guess the legislators and the executive immediately needs to take cognizance of, especially the pictorial warning for alcohol, our planning, pollution, food safety. We already have a law with respect to one aspect, that is your FSI that you highlighted, but others, I guess, can be prioritized, and we need to have more consultations on different aspects of them. So we'll have more consultations on them. With that, can I move on to the question answer session if all the panelists agree for another 10 minutes extension? I know we have run out of time, but I have received multiple questions. I'll just try to filter them. If for another 10 minutes, we can also.
Nandita, you can take.
All right, sir. I'll take a few of them. Some are general comments. There is one important question which was asked by Dr. Bishwa Kalyan Das, and it's directed to Dr. Sharmila. He's directed it. So he wants to know that there is a urban-rural divide in the data on cancer. Cervical and breast cancers are higher in one place and reverse in other. Then how do you see a comprehensive regulation would assist, because this may be because of the lifestyle, and this cannot be in any way regulated through asymmetrical regulations. And at the same time, law cannot be different for different places. What is your take on that? That's one of the questions that have come. Ma'am, your quick take on that. Ma'am, you're on mute. We can't hear you. You're not audible. Not audible, ma'am. I'm so sorry, ma'am, you're not audible. Any other doctor would want to take that in the meantime?
In general, what I would say, I don't know which were the two cancers. I'm sorry, which were the two cancers which you were dealing with?
Ma'am, he'd highlighted breast and cervical cancer.
Okay, so all interventions, so that's a population-based approach. So in public health, when you take population-based approach, some populations benefit more, some populations benefit less. That does not mean that you do not impose those regulations. Shamila has come on, so she can take the question. Because you want everybody to benefit, those with high risk, those with medium risk, and those with low risk. So interventions which will lower the cancer rates have to be implemented irrespective of the rates in that area. Over to Shamila, I think she's back.
No.
So
we take another question. The next question.
Okay, we'll take another question. There is one question by Neha. She asks, is it feasible from a societal perspective to ensure personalized cancer therapy for Indian patients? And is it possible through any of the public health laws? Anyone would want to take that? About personalized medicine? Dr. Majid, what's your opinion on personalized medicine?
To be very honest, to understand how you have a personalized medicine, you can have a medicine for specific cancers. You cannot have a personalized, if I'm not getting the question clear.
Maybe she wants to talk about precision medicines the way we have in US, the patent laws, they determine the amount. That's how I got it. I'm not too sure about, I've not received a clarification.
So normally what happens, the personalized medicines, normally the government can go in. For example, if I take the example of Corona, so many injections are patent. And if the US has removed the patent of Pfizer vaccine, the government has the authority to do so. If a certain medicine is benefiting the society, then we should go for the law and wait for it.
Okay.
If certain medicine...
Can I add something? Okay. Go ahead, sir. Sorry.
Yeah, please. So normally, what happens is, what I could understand from that, the patency of the medicine. I think that's what, yes, the government has the right. It feels like it's an emergency, and rather than giving a patency to a company, like for 10 years, 5 years, this is how it goes. But in case like a cancer, a deadly disease, the government can go and enforce a law and take out the patency of that medicine. Yes.
Thank you,
one more interesting question I saw there. I was just going through it, like why the celebrities who get treated outside are cured. Our celebrity sitting here is cured in India. One example. If you go to Rajesh Khanna, Vinod Khanna, Rishi Kapoor, Shashi Kapoor, or Irfan Khan, where did these people all get the treatment from? Or Nargis Dutt. You see, Nargis Dutt, she had a pancreatic cancer, Sanjay Dutt's mother. Her body came to India. So it is not that for a better treatment they are going there. It is for privacy. They get isolated from people. They get less calls. They may get a better environment. That's the reason they go. Or else you see our celebrity sitting here is cured in India. That's what I could read one of the questions there. Yes, why do people going abroad are cured and why not in India? I say in India they are cured, but for privacy they want to go. Yes, there's no problem in spending more money. The difference
Dr.
is
Majid,
one consultation. Yeah.
Sorry to intervene. I just have a question on this, a counter question, because we experienced it recently. Some of the cancer tests, the genetic sequencing is not available in India. So what's your take on that? The diagnostics are not available.
No. The diagnostics are available. BRCA1, for example, for breast cancer. If you see Angelina Jolie, the actress, her mother had breast cancer. Her mother had breast cancer and she got her both breasts removed because her cancer risk was high. But in India, this type of preventive cancer treatment is not up. If I tell someone who comes, you have to get your both breasts removed and do it, people will not go for it. The lack of education, the lack of awareness, we do have good number of markers with us, because what normally happens is the medicines or the research all over the world is the same. It's the same. Okay, earlier they used to say we are sending the biopsy to Tata. You get the biopsy done everywhere in India. So it is just the lack of awareness and the patience. No one like Angela Jolie will come up and say, remove my both breasts and I want to be safe from. One is we are not able to, like for example, in a family, there's a chance of a hereditary 5% of the cancer. But we are, one is we are not that aggressive as in the other parts of the world. But I think we have the equal resources, may not be in a tertiary, a smaller PHC, but in a tertiary care center, we do have. And I also agree that what hospitals you might be having in a capital of Odisha or a capital of Delhi will not have in a rural area. But we need to balance this by providing the same resources at that level also. I don't know whether I've answered your question or no.
No. So you've in fact covered all the other host of questions that were put in the chat box. Thank you so much, sir. Ma'am had raised a hand.
I just wanted to kind of contribute a little bit more and add to what Dr. Majid is saying. See, cancers, you can't paint everything with the same brush. So a lot of it depends on which cancer it is and at what stage it has been diagnosed. So as when you diagnose cancers at a very early stage, at that stage, they're completely curable. Certain types of cancers, again, don't rapidly spread and they are completely curable. But certain cancers, unfortunately, world over, for example, pancreatic cancer or adenocarcinoma of the stomach normally show up much later in the stage when it has already spread. They don't show symptoms earlier. At that stage, curative, it would be incorrect to use the word curative, and it's more about how long, 5 years or 10 years, the quality of life you can impart to the patient without recurrence. So I think those aspects are also important. And also I'd like to just say the genes are important, but they contribute in the larger game of things. If you look at the population level, at the global level, genes contribute 5 to 10% of the risk. But even if you have the gene, if you have the genotype, it does not mean the gene expresses itself. A lot of the environmental issues determine whether the genes express themselves. So therefore, some people may have the gene and some people choose not to get themselves tested because they don't want to be living with that sword throughout the life. It's a very personal decision because you may have the gene, but it may not express itself. 90 or more than 90% of the breast cancers, there is no genetic component. So I just wanted to kind of put this in perspective that and Angela Jolie comes from a completely different thing. She had the best medical care available. She had the best plastic surgeons available. That was her personal choice to go in for that. So I'm not sure it would be right to say that every person with the BRCA gene should go in for a thing. It's a very personal choice, but I'm just putting things at the larger level.
That Angelina Jolie incident has led to a lot of patent issues, patent questions in US with US Supreme Court, reforming the laws in molecular of pathology association versus myriad genetics case, because it was the high cost even in US that prompted a lot of other pathologists to file an application. So I guess apart from the personal aspect that you're talking about, it's also about money, which India we face. With that, I guess we can close our question answer session. Many of the questions have been answered by Dr. Majid in an overview. I guess he had the benefit of reading them all and answering them in one. And I would now request Dr. Yogesh Pratap Singh, our registrar, to please propose a word of thanks for such an enlightening session that we had today. Over to you, sir.
Thank you, Nandita. I'm audible? Can you hear me?
Yes, sir, we do.
Okay, thank you. It was indeed a very enlightening session and unique also because it combined law, policy and medical science, which is not normal. Our country started the National Cancer Control Program in 75-76, but it was only in 1985 we shifted towards prevention. So, however, the main focus to this cancer program was on the treatment of the cancer by establishing various regional centers, a function which is still overseas. Another main task of this national program was the creation and management of the National Cancer Registry Program, which is responsible for providing nationwide cancer statistics in India. While these regional centers and National Cancer Registry Program have been quite important, significant in driving our management and understanding of cancer in India, there have not been any systematic nationwide improvement in prevention of cancer by using screening and or early detection. Some of the experts, I think they already mentioned. At the very least, for the most common cancers in India, breast and cervical cancer in women and head and neck cancer in men. In 2008, National Program for Prevention of Cancer, Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke was also started. Cancer was not part of this program and was later included only in 2009. The operational guidelines suggest that cancer prevention is still not a priority, as the emphasis remains on treatment of cancer and strengthening the tertiary cancer hospitals rather than prevention via screening or early detection of the cancer. This was one of the reasons for conceiving this Center for Public Health Law in National Law University. We don't find centers of public health law in law universities in general, so that we can bring out policy related issues which doctors face in the field. The center is relatively new, but we are actively working with PHFI and the International Union so that we can do some significant change with respect to policy and law. I am grateful to all the learned speakers, Dr. Sarmila, Dr. Majid, Dr. David Peterson, Dr. Amit Yadav, Dr. Shipra, Dr. Nandini Valat, Dr. Cephalika for helping us to organize this wonderful program on a very short notice. And I deeply thank all the learned speakers for sharing their views, removing so many misconceptions with respect to treatment of the cancer and the challenges which they face in the field as practitioners, and the challenges with respect to law and policy which we should address and we should discourse in future. On behalf of NLUO, I extend my deepest gratitude to all of you and our Vice Chancellor, Professor Ved, for permitting us to organize this event and helping us to get in contact with Dr. Majid, who gave such a wonderful presentation and removed so many misconceptions about the cancer surgery and treatment of cancer. Thank you so much, and we seek support and blessings of all these experts in future also for organizing such webinars in the Law University. Thank you so much.
Okay.
Thank you so much, sir. Thank you, everyone. Stay safe.
Thank you.
Thank you. Thank you.
Thank you.